recordings. So now I'm recording. Um, I did take the time to go through the whole chart and answer all the questions.
Wait, before you
Um,
continue,
hmm,
did you go to Sweeney's class today or no? Just curious.
no.
Okay. Sorry.
I don't think
Because
Sweeney went to Sweeney's class today.
I almost did, but then I was like, no, it's not worth it.
No, it was funny because she walked into lab and she said that she woke up late. So I really don't think that she even went to her own class. It's kind of silly.
Okay.
Oh no,
I was just curious.
I was
Okay, sorry.
tired. No, you're good. No, I didn't go. I was sleeping. Um, but yeah, so I figured that like I can make, because I think last time it was helpful that there was like a PDF. So this is another PDF with all the questions pretty much answered. So I figured we can just kind of run through them. A lot of things did repeat from the midterm in terms of content. So there's some overlapping stuff, but I thought this would be really good to like go over it all now. So it's like something's in your head, like for the exam. And yeah, I think now looking at it, I might have missed the question, or maybe I didn't. I don't know.
I don't think you missed any. Some of them are, I think two of them were like related topics,
Yeah, I think I
like
combined
similar.
one.
Yeah. You didn't miss
Yeah, I
any.
don't know. If I miss something, I'll edit after.
Mhm.
Um, but anyhow, okay. So I put the question in the page so that you could always like go back to it after and like look at it. But like the first question that she had that she said will be our question one is promoting GI health. And like what are some ways that just from what we know that we can do to help promote GI health?
Fluid
Fiber
and fiber.
Mm-hmm.
and lots of fluids. We want to make sure they're hydrated and not
Yeah.
constipated.
What else?
Eating a lot of fruits and vegetables.
Mm-hmm. We can also exercise, right?
Physical
Yeah, I was
activity.
gonna say that next.
Right? Exercising, fruits and vegetables, fluid and fiber, all very good. But yeah, I think I did miss the question on selected GI health conditions, but that's okay. That's just we'll just go through the 39 others. But question two is about dysphagia. And so what sorts of things do we do or interventions that we can implement to help a patient who has difficulty swallowing?
Make sure the patient is sitting upright when eating and provide like adequate fluid intake.
Mm-hmm.
Make sure like to give them small bites with their meals.
Mm-hmm. We could also like follow a speech language pathologist very closely because they're the ones that will let us know what they're cleared for in terms of their ability to swallow, right? Like a soft diet and maybe thickened liquids to help with swallowing, sitting upright, and then while they're eating and 30 minutes after, and small bites, I think are the most important points. But I also had like having a suction machine like very accessible because sometimes they might choke or something might get stuck and we need a suction device. So she told us to go to page 151 for the next question on nutritional needs. So what do you think are some important vitamins or minerals that an older person might need?
Well, vitamin D, especially, and like calcium, especially for women because after menopause, um, like the hormones change everything.
Mm-hmm. Yeah, I mean, a lot of vitamins I think are important. We need to have most of the essential vitamins every day, but some issues that we might have is that taking vitamin D is good, but it can cause calcium deposits. So it could be bad if they take too much, right? Vitamin K can be really good, but it can cause clotting if they take too much of it. Folic acid is great, as you said, especially for like pregnancy and things like that, but it could mask signs and symptoms of vitamin B12 deficiency if it's overused. Same thing with calcium can cause, kidney stones. That's a problem with taking too much calcium and even constipation. Potassium is important, but it can cause arrhythmias and EKG changes and cardiac arrest. And it also said in the textbook that some vitamins that are and nutrients that are found to be deficient in older adults include niacin, riboflavin, thiamine, vitamins B6, C, and D are the most common ones to be deficient in older adults. Now, she also said to look at kidney and nutritional supplements. The only thing that I pretty much found here for this is that calcium consumption of more than 2,000 milligrams can lead to problems such as kidney stones and an increased risk for cancer. I don't think I have anything else. I couldn't find necessarily anything else as of right now. I don't know if anyone else spent time yet looking at the questions or looking at the sections in the textbook if they found anything else, but I saw calcium as being the most prominent one to affect the kidneys.
Yeah, that's all I saw too.
Okay. So the next one I have is constipation. So we should know this one. So what are the 3 things that we should tell a patient to do to prevent constipation?
Lots of fluids.
Mm-hmm.
Don't take laxatives. That will make it worse.
Mm-hmm. What else?
Eat prunes.
You could. Yeah, they're good.
Foods with fiber, so maybe like an apple with the skin on it.
Mm-hmm. So fibers, fluids, and there's one more like really important thing that they could also do.
Exercise or like activity.
Yes, exercise. So increase fiber, and increase exercise. Very, very good for patients who are constipated. So then we have sleep promotion. So what are some ways that we can promote sleep in our elderly patients?
Well, we want to keep them on a schedule or like a routine. Make sure they're turning their lights off. Maybe some warm milk before bed.
Mm-hmm. Yeah, right. Like we want to reduce any sort of noise or stimulation because that can keep them up, right? Like you said, having a bedtime routine. Certain medications might also affect your sleep cycle, so maybe taking them at different times if that's applicable. Things like pain or drinking or eating something maybe too late could make you go to the bathroom at night, which could interfere with your sleep. So we want to reduce as many distractions or, things that can affect our sleep as much as possible. I think that would be the main thing. And I think a question like that would be pretty simplistic. It would be like, what would be a good way to help promote sleep? And it might say like reduce sound or reduce lighting and things like that. So the next question that I saw was, it said just pathophysiology signs and assessment findings. So the way I saw this is I saw chronic stress and I saw things that said how to respond to stress and like do lifestyle changes and figuring out ways to respond to stress in a healthy manner, like eating good and exercise and rest and maybe even praying, because it said that unrelieved chronic stress can lead to heart disease, hypertension, cerebrovascular accidents, ulcers, and other health disorders. I don't know if anybody else found anything or specific topics for this question that they'd want to include for this.
Can you repeat that?
Oh, yeah. So for this question, I basically saw, I didn't really find anything on that particular page other than it said like chronic stress can lead to, lots of different health disorders like heart disease, hypertension, cerebrovascular accidents, and ulcers. So I figured that's what they mean by pathophysiology, signs, and assessment findings. I didn't really know exactly what to put for this particular question.
Well, I guess just the basics like stress increases our blood pressure over time. I guess stuff like that.
Yeah, I guess like anything that can, like affect your health in any way. And I think a question like this would be relatively like simple. Like I said, if there's anything else to add, this is what I have as of now. I didn't really find anything else specifically on that page or that area. But yeah, so the next thing that I have for question 9 is common sleep patterns. So does anybody remember like what sorts of sleep patterns that the elderly or older adult population typically present with?
They fall asleep earlier, but wake earlier as well.
Mm-hmm.
I don't know if this is true, but I feel like they're light sleepers. So we have to make sure that there's nothing like disturbing their sleep.
Yeah, I mean they would be light sleepers because they only are in stages 1 and 2 really of sleep compared to 3 and 4, and they don't really go into REM sleep, so they're never really in deep sleep. So yeah, they would be light sleepers. I think basically what the idea is, as I think Ashley said that, the idea that they fall asleep earlier and then wake up earlier, and that they might need daytime naps. That's what I saw for this question. So for question 10, we already kind of talked about ways to promote sleep, right? So reducing lights, sounds, helping with pain, not having caffeine or exposure to blue lights before bed, and adjusting to a new environment might also be sort of stressful or preventing them from sleeping. Loud noises, bright lights, all can affect sleep. And as we mentioned, stress can also cause problems with sleep, and we could even give a protein or carbohydrate snack at bedtime to encourage sleep. So there's definitely a lot of different things that we can do to help promote sleep. So we already talked about the stages of sleep. We already said that they pretty much aren't really in non-REM or REM. They're not really in stages 3 and 4. They mainly spend their time in stages 1 and 2 of sleep. Now, I thought in terms of this question 12, communication on sleep patterns associated with aging, I thought it was to tell them, that they might be more like nodding off, or, they don't have as much sleep because they're in those 1 and 2 stages of sleep, and that they tend to fall asleep earlier and wake up earlier. I don't know if anybody has anything to add for that. No. Okay. So we also have the question that kind of repeated in last time, and it actually relates to 2 parts, questions 13 and 14. So ways to prevent falls. So what are some things that we can control in the environment to help prevent falls?
Good lighting, no rugs,
Mm-hmm.
handlebars like in the shower, a
Mm-hmm.
shower chair,
Yeah.
a smoke alarm.
Yeah. Definitely nothing on the floors. It could definitely help having levers, right? So they're not trying to try really hard to turn other different ones. No rugs. And something I saw in the textbook that it said like no scatter rugs, but like that honestly I forgot what I was gonna say. I don't know why. I just completely lost what I was gonna say. Oh, contrasting floors. Like they should have contrasting floors when they're changing levels. Um, Shower stalls, rails in the shower, especially like having like a seat outside the shower because the heat can make them hypotensive and they can have a risk for falls. And electrical appliance can be a safety problem, so we want them to have gas stoves and things like that just for their own safety, not as much for falls, but just the idea of safety. And yeah, nothing on the floors, right? Keep the floors clear and free of anything. So the next thing is environmental risk associated with sensory deficits. So if we have visual problems, right, they might have problems with seeing things on the floor and they might have increased risk for falls. So as we said already, have good lighting, eliminate clutter on stairways or on floors, contrasting colors on the stairs, providing signals when to change in a level is happening. Bright colors help because they might not be able to see so clearly the those darker monotone colors. And to compensate for their reduced vision, we should approach them from the front instead of the back or the side. Okay, so when we're talking to them, I feel like that could be a question on the exam, is to talk facing them. Now, hearing deficits are also a safety risk, right? So they might not hear their smoke alarms or their fire alarms. So it might be good to have someone in the house with them, or maybe like they said, a trained dog, because of the fact that they could help identify problems that are happening in the house because they might not be able to hear certain things. Conversations for hearing impaired individuals during the night can be facilitated by, this is that weird question that I saw on the course point that said you could put the earpiece of the stethoscope into their impaired ears and speak into the bell or the diaphragm. I feel like that might be a question on the exam, just because course point sometimes has interesting answers to questions, and that's one of the things you can do for hearing impaired patients. And other deficits like sensory, such as like their touch or their taste, right? They might not be able to smell things, so that might also be good to have people around who can smell. Like they might not be able to smell a fire or the gas being on or things like that. They should use gas stoves in that reason because they have reduced touch, right? They might have problems where it comes to skin breakdown, so we want them to move and change positions and be careful with bathroom temperatures, especially since they don't have good touch receptors or temperature receptors anymore. So we want to make sure that someone is there to help with that. For question 16, it says nursing problem highlights. I just took a screenshot of it, and it kind of is just more or less talking about like the different hazards and what happens when, you know, someone might have a history of falls. And this was the only like problem highlight that I saw on that page, so I screenshotted it. And then like as we're studying for the exam, we could look over the different types of interventions that are in this. Is there anything that anyone had to add for this question, or do they see something differently that I might be missing?
Sorry, I'm reading it. Hold on.
It's okay. So I figured, like I said, this was something that I saw in the textbook on that page. So I took a screenshot of it. I think this is what they might be talking about because I couldn't find anything in that specific chapter that had to do with a hip fracture. But I thought it had to do with risk of accidents or injuries, right? Because if they're coming out of a procedure, a hip fracture, they might have trouble walking and trouble getting to places. So they're very high risk for falls.
Yeah, that's what I was gonna say. It's probably just like a fall risk question.
Yeah, that's why I put this chart in here because it was the only problem highlights that I saw in the thing.
Yeah.
For question 17, assessment for gait abnormalities. So I found this right from the textbook. It was like in a table 21-4, and I like copied everything. So you look for things like abnormal gait, abnormal structures, dysfunction of a limb. If they're walking on one side, they are having tremors, paralysis, weakness, atrophy of a limb, or that limb's not really working. redness or swelling of a joint. The use of a cane, walker, or wheelchair is indications that they have a gait abnormality. But for abnormal gait, certain things that are like in that like area, I copied it from the chart, was that they might have ataxia, which is unsteady, uncoordinated feet raised while stepping and then dropped flat on the floor. So they kind of raise the foot up and it drops. They have foot slapping, which is basically every time they walk, they just slam down on the floor. They might be hemiplegic, or one foot drops and the other one kind of drags, and one foot does that and it doesn't really like, it's kind of like a limping leg. Parkinsonian is another type of abnormal gait, which they have that shuffling, really short steps, maybe a little flexion of the hips and the knees, and you kind of lean forward, very characteristic of Parkinson's disease. They might walk in something called scissors, which are slow steps and the legs are crossed while stepping. Or they might have spastic, which is uncoordinated jerking gait, where the legs are really stiff and the toes drag. I don't know if anyone else has anything to add for this, but this is what I found for this question.
All good so far.
Okay. So then there's question 18, which has to deal with low bone density interventions in osteoporosis. So what are some things that we tell our patient who has osteoporosis?
To take their calcium and their vitamin D
Why?
because they're fragile. Their bones are fragile. They could break, fracture, and
Mm-hmm.
it's very dangerous. An elderly
Yeah.
having a hip fracture could literally cause them to die, so they need to be taking their calcium and their vitamin D, most importantly, or any other medication that could be prescribed if they have severe osteoporosis.
Exactly, right? Because calcium is found in bones and calcium is needed for bone. So osteoporosis means brittling of the bone and they're losing some of that calcium. So vitamin D helps with absorption of calcium. So when we take our calcium, we have a better chance of it getting to the bones and really helping those patients with osteoporosis. We also want to do things like avoiding heavy lifting, jumping, or other activities that can result in a fracture because their bones are really, really fragile. So we don't want them to go to the gym and say, hey, I'm going to lift that 50-pound weight. That might not be so good for our fragile patients. But as some of you were saying, the most important thing would be vitamin D, calcium, vitamin C, and protein intake, and avoid heavy lifting, jumping, or activities that can result in fracture. Okay, so they should be very careful. They could walk, right? Because walking is still good for the bones and giving them strength, but we don't want them to do, things like really heavy lifting. We don't want them to deadlift or do like things like that at the gym, okay? So there's another thing called in question 19, there's something called onychomycosis. I'm terrible at saying things. But it's a fungal infection of the nail or the nail bed at the toes, which makes those nails appear like really enlarged and thick. And it's an infection. So we're going to give them antifungals. But I think knowing the definition that it's a fungus infection that displaces the nail and it's pushed into the skin and it causes pain, I think that's what I would know for that. And that obviously, since it's a fungal infection, it might say, what should you give? An antifungal. Does anybody have anything else to add?
No.
Okay. So for question 20, it's the right and safe medication administration on page 211. I didn't find the rights, but I wrote some of them down, like right patient, right documentation, right medication, right route, right dose, right frequency, right time, right education. I also copied some things that I thought were important that it said to ensure that oral medications achieve full benefit, encourage good oral hygiene, ample fluids, and proper positioning to facilitate swallowing. And that older adults are at risk for circulatory overload during intravenous drug therapy, so close monitoring is essential. I don't have anything else to add that maybe that just that older adults are at a higher risk for adverse effects. But I don't know if you have anything else to add.
No, I think this one was on the last exam too, and we covered it.
Okay. So for food and drug interactions, she specifically put furosemide, and I went to the chart and I found it. And all it said was that furosemide, remember, is a diuretic. Diuretics excrete water and fluid from the body and take some of those electrolytes with us. So it increases excretion of like calcium, magnesium, potassium, and zinc. I'd also add sodium because it does do that. But yeah, those are the things that it does. It excretes calcium, magnesium, potassium, sodium, and zinc. The next thing is for question 22, education of home care for patients on anticoagulants. Now, there was a lot of stuff. So I kind of copied everything that I pretty much saw for this, but I don't have to read all this because like we could read it closer to the final. But anticoagulants, what are some things that we really have to watch out for on patients who are taking heparin or warfarin? What do we teach? What do we tell them?
To prevent from banging or injuring themselves because they could hemorrhage.
Yeah, right. Because they're very at risk for bleeding. So we want them to avoid contact sports, right? Use soft bristle toothbrushes, electric razors, things like that. Now, aspirin can increase the effects of oral anticoagulants. Not really good, right? What sort of food do we watch out for someone who takes warfarin and why? It's a particular vitamin.
Would it be
Vitamin K,
kale with vitamin K?
Yes. And where is vitamin K found?
leafy greens.
Mm-hmm. So like our asparagus, our cabbages, our cauliflower, especially those green leafy vegetables, not so good for patients on warfarin because vitamin K is the antidote for warfarin and it increased clotting. Just like that question we spoke about earlier about vitamin K is great until like you take too much and they clot a lot. And what about heparin? What is the antidote for heparin?
Protamine, sulfate.
Yeah. Yes, protamine sulfate. And when someone takes heparin and warfarin, what sorts of values should they be monitoring for?
INR, PTT.
Mm-hmm. PT, which should normally be 60 to 80 seconds for our heparin patients. And like I said, I don't know if I've explained this here, but I know I've explained it to the juniors, is I didn't know this, but clotting times are normally like maybe 30 to 40, but when they're taking heparin, we want it 60 to 80 because that increased clotting time means that it's taking longer for a clot to form. So in that range, it's slower for a clot to form, which means that the medication is doing its job. The same reason the INR level is 2 to 3 instead of for a normal person being 1 or less, because the 2 to 3 lets us know that they're having a delayed ability to clot, which is really good. I think those are the most important things, like teaching them to monitor their labs, watch out for bleeding precautions, be careful with vitamin K and things like that. So, like I said, I added a whole bunch of stuff in here. You could read it because, like I said, I'm gonna send it to everyone after. So you could just let me know if there's anything I missed or whatever. It's the draft per se. But yeah, I just wanted to put that out there that I think those are the most important points when it comes to the anticoagulants because those are some of the things that we've been tested on in the past. What diet advice do we give to someone who is who has hypertension?
Low salt intake?
Mm-hmm. Yeah, we want them to reduce salt. So we want a diet that's rich in fruit and vegetables and whole grains, low salt diet, and a diet that we call that like they use typically is the DASH diet, or dietary approaches to stop hypertension is the diet that they include. So I would say probably the question would either say low salt diet, like on our midterm, or it might mention DASH diet. So I put both. I couldn't find anything for question 24, which said diet for poor appetite interventions, but I figured that since they're having a poor appetite, we'll want them to have small, frequent meals every day so that they can keep their nutrition going. I don't know if anyone has anything to add. No? Okay. So the next thing we have is asthma intervention. So what are some interventions in general for a person to help clear the airway?
Bronchodilator
Mm-hmm.
and a steroid, a corticosteroid, I think.
Yeah, you could help those. Those are definitely going to help promote the airway and help you breathe, especially if they're in like an asthma attack or something, right? But we could also do things like, could we raise the head of the bed?
Yes.
We could suction them, right, to help clear any sort of things in the airway. Breathing exercises, right, like the incentive spirometer and things like that. And also telling them to turn, cough, and deep breathe every 2 hours is the things that I have for this topic.
Can you just explain why that would be helpful?
So,
coughing and
which one?
the coughing and deep breathing.
Okay, so I think from my understanding is that sometimes when you have asthma, you have increased secretions as a potential consequence, and that can obstruct the airway. So if we have them cough and deep breathe every 2 hours, we're helping them remove any potential secretion buildup, and that also helps clear the airway.
Oh, okay. That makes sense.
Okay. I'm happy that made sense. Okay. So the next thing we have is, I think this one was pretty simple. What bed position should we do if someone is having shortness of breath?
5 Fowlers.
Yeah, right. Fowls. Like, make sure we get them at least 30 degrees, right? We want to get them 30 to 45 degrees. And we don't want them laying down because that's not going to help with them breathing. Okay. So question 27 is, what are some abnormal urine analysis finding? What are things we should not find in our urine?
Albumin. Yeah.
Okay.
Yeah.
Protein.
Yeah, no proteins. What else shouldn't be in our urine normally?
Glucose.
What else shouldn't be in our urine? What about bacteria? Should we have bacteria in our urine or
No.
like nitrates?
No.
No, right? That's not good. That's like a UTI or something.
Yeah.
Their specific gravity should be normally between 1.005 and 1.025. So those are the main things, right? Like the urine should be free of sugar, free of protein, shouldn't have bacteria. Other things that we shouldn't see in the urine sample, it shouldn't have an odor, right? A really strong odor. It shouldn't be really dark. It shouldn't be red because that's the presence of blood. If we see blood in the urine, that's not normal either. If it's yellow or brown or green or brown, that means there's obstruction in the bile duct or they might have jaundice. Orange urine is from medication, also not really normal, but only in that medication it is.
When
Dark
it's
brown
really
urine.
concentrated, it's also patient being dehydrated.
Yes, because they're not really peeing much. So they're letting a lot out, a lot of like solutes and concentrated stuff in their urine in that one little time that they're going to the bathroom. And dark brown urine, not good. Also a sign of possible cancer or blood in the urine. So all that stuff is bad. But I think when they're talking about in terms of urinalysis, we're talking about no sugar, no proteins, right? No bacteria in there. We shouldn't find any of that, and no blood in the urine. So for reproductive system health for question 28, I had no idea what to put, but I kind of just copied the common female reproductive diseases or disorders that you might find.
I think, sorry, I
Hmm?
think it might be a question on like vulvitis, because when I did the prep view, that one kept coming up a lot.
Okay, so I'll put
And
that.
like how it's like itchy or inflamed or both. But yeah, that was a course point question, yeah.
Okay. So itchiness, inflamed. So I didn't really know. So I just kind of put that one, and all the things that you can find, cancers, different cancers, dyspareunia, which is like pain that you get during sex or before sex, cancer of the breast. But okay, vulva, I'll remember that one. I think maybe that's the one that she's talking about. Okay. Like I said, the only question I didn't get was question 3, unselected GI conditions, but I figured as I go through the course point, whatever ones I see, I will add them in the notes. And for medications producing nocturia, the only thing I found was nocturia means that they have a lot of nighttime urination. And the only thing I found that long-acting diuretics like thiazides cause this. I didn't find anything else in the textbook. Okay. So then we have question 30, which is promoting independence in a patient with a neurological condition, right? So if somebody has things like Alzheimer's or Parkinson's or things, right? Assistive devices, hallway rails, grab bars in the bathroom, all relating to, right? Because they have a neurological condition, so they might have a risk for fall. So it's good to have fall risk precautions, grab rails anywhere, bathroom bars, things like that. Maybe periodic visits by a home nurse or by a friend, someone who could check in with them. Even though they might perform things slowly, allowing them to do it promotes independence and being patient with them. Sometimes there might be personality changes with patients who have neurological problems. So they might be depressed or things like that. So their reactions might be just based on, the changes that they're going through, and we need to be really patient and understanding with them. I think that's just the main ideas is like promoting safety. And I think the promoting independence would be, if it said like, I feel like the question might be like, the patient is really doing things slowly and they can't do it as fast. Like, what should they do? Like, be patient and let them, because that's good. I feel like that's the type of question that would be on the exam. So, what are some things that we can do for a person who has visual problems? What are some ways that we can help them or make it easier because they're having problems seeing? What are some things that we could do for them?
Using like a magnifying glass when showing them things.
Yeah, we could even print things in larger fonts so it's not as hard on the eyes. We said before when they have visual deficits, speaking to them like in the frontal perspective. Don't have glaring lights on them because that's going to hurt their ability to see things, and avoiding glare from windows by using sheer curtains or stained windows. Place a lot of items that they use frequently in their visual field so it's right there, easy to get to. Use bright colors and contrasting colors on doorways and stairs for changes in levels, makes it easier for them to recognize it. And identify personal belongings and things like that by using unique designs instead of letters and numbers. This is what I got from a chart in the textbook. Now I couldn't find anything specifically about dangers post-cataract surgery. All I found is that, they might have risk for eye infections or, potential visual loss. Like it said, eye infections, loss of vitreous humor, or slipping of the implant. I don't have anything else. I don't know if anyone has anything for this specific question. Okay. So that's all I found. I didn't see anything specifically in the textbook for that in that chapter at all. For question 33, for hearing deficits, what are things that are normal, right? Like I think it's just like presbycusis. I think that's how you say it. That's normal, changes in hearing that you get as someone ages, right? I think they all have some degree of hearing loss, which is just trying to say that's normal, but not like if they completely can't hear, that's not normal. So I also added for this on a section, it said patient care. So I said the first action in caring for someone with a hearing deficit is to encourage autometric examination. I thought that could be a potential question. And I also included that physical, emotional, and social health can be seriously affected by this deficit. And I think the question either is going to be the idea that presbycusis is, normal hearing changes. And if someone does have a hearing deficit, we want them to go to somebody and get an examination. And I didn't find, like I said, something specifically also in the textbook for this question, 34, on valid reasons for cosmetic surgery. But what would be a reason for an elderly person to get a cosmetic surgery?
For the elderly,
Mm-hmm.
maybe like reconstructive if they suffered burns and stuff.
That's what I was thinking too, right? Like if they had a
Yeah.
burn or a problem or like maybe a skin cancer, that would be
Yeah.
an appropriate reason to get a cosmetic surgery. I was also thinking they said sometimes they might do like Botox or things to make them look a little more youthful. Some surgeries like that, but they said in the textbook, not a rational reason includes an underlying problem such as depression or a neurologic disorder. Counseling and therapy may be more pressing need than surgery in those circumstances. But yeah, I didn't see anything about the good reasons. I only saw that they shouldn't do it if they're depressed or they have like a neurological disorder, because then they might not be doing it for the appropriate reasons. Okay, so what is how can we recognize, right, a person should go to the skin doctor and look at this mole that they have in it. But what are some things that we might see that might tell us, hey, we should probably go get this mole checked out?
If it's a mole that's like changing in color or size.
Or
Mm-hmm.
irregular a shape and it's elevated,
Yeah.
palpated.
What about color, right? If it changes or there's variations in color, that might not
It's
be
like kind
normal.
of purplish is not a good sign.
Mm-mm. Diameter, if it's more than 6 millimeters, or the size of a pencil eraser, if it's more than that, we're looking at potentially a cancerous mole. And I put other variations include elevation in height from the skin surface, as that was mentioned, a change in feeling, itchiness, tenderness, pain, tendency to bleed if scratched. I said this is what I thought would be the advice for changes in mole. Go see your doctor if you have any of these changes. Okay, so question 36 is a diabetic patient with handwriting changes. The only thing I found in the textbook was Dupuytren's contracture, which is a fixed flexion of the hands due to thickening of fibrous tissue under the skin of the palms and fingers. And that is a risk for a person with diabetes mellitus. That's the only thing I was able to find for this question. I don't know if anybody was able to find anything else. Okay. So that's all I was able to find. Maybe during the questions, what I like to do when I do the course point questions is to look through it. And if I see a question or a topic or an idea that relates to this potential topic, I try to fill in any extra notes that I can. What about signs of cancer? What might be some signs of cancer? It's okay if you don't know either, because there was a little thing in the textbook and it's like a little mnemonic and they called it caution. So the first one, or the C, stands for change in bowel or bladder habits. The A stands for a sore that does not heal. The U in caution stands for unusual bleeding or drainage. The T stands for thickening or lump in the breast or elsewhere. Indigestion is the I, or swallowing difficulty. O for obvious change in a wart or mole. And N in caution for nagging, persistent cough or hoarseness. That's what the signs of cancer said. Those were the signs, and it goes by the little mnemonic caution. Now question 38 is, what is the goal of palliative care? What is palliative care?
Palliative care is providing care to relieve like pain and discomfort.
Yes, the goal is to promote the best quality of life for their chronic disease that can't be cured. So
Exactly.
we want to maintain or improve their self-care capacity, manage the disease effectively, like manage the symptoms, boost the body's healing abilities naturally, right? Because we have a strong immune system and sometimes we forget to use it. Delay deterioration and decline, achieve the highest possible quality of life, and hopefully they will die comfortably and with dignity. And we serve as healers in this role if we're a part of the palliative care process, and we help guide individuals with chronic conditions to achieve their maximum potential and highest attainable quality of life. Now for question 39, it's a decline in immune response. So I said that's a normal change that happens as you age, but there's an increased incidence of cancer that can result from age-related changes because of the reduced ability to resist disease or prolonged exposure to carcinogens. Does anybody have anything else to add for that question? Or any of the other questions so far? No. Okay, that's okay. I usually take silences now. And then the last question, question 40, is the most important action to keep a hospitalized patient free from infection. So what is, my mind went to one thing because I couldn't find it specifically in the textbook, but my mind went to one thing that always seems to be the answer for keeping any patient free from infection. And what do you all think that might be?
Hand hygiene.
That's exactly what my mind went to. I think that's the answer to this question because you touch your patient, you give them their medications, and if you don't have good hand hygiene, then they have more likely of a chance to get an infection. Other things that I found in the textbook included promoting good hydration and nutritional status, monitoring vitals, mental status, general health status, maintaining intact skin by making sure they, turn and position them every 2 hours, especially if they're on bed rest, avoiding immobility, ensuring a monococcal and influenza vaccine. So, in vaccines is another great way to keep free of infection or prevent infections, maintaining a clean environment, restricting contact with persons who have infections or suspected infections, storing food properly, preventing injuries, and adhering to infection control practices. So this is all that I have. I'm gonna stop the recording here.